Good afternoon. Good afternoon, everyone, and welcome to the next session, Vitreoretinal Surgery, Part 1. I'm Don D'Amico, and I will moderate the first four presentations, which, as you will note, are all being given by women who are both extremely accomplished and talented surgeons and wonderful role models in ophthalmology. Our first presentation will be by Phoebe Lin, and she will speak to us on surgical complications in uveitis. Dr. Lin.
Thank you so much to the moderators and the organizers of this meeting. These are my financial disclosures, so I'll just have time to cover a couple topics here in surgical complications of uveitis, including uveitic macular holes, uveitic detachments, and retinoschisis. So uveitic macular holes are more prevalent than idiopathic macular holes. They also occur at a younger age, and the etiology is mixed, meaning that uveitis patients have a higher rate of macular interface abnormalities, a high rate of recurrent and chronic CME, and then you have that rare type, which is due to necrotic macular retinitis, which can cause a macular hole as well, and they're obviously not excluded from having more similar to the idiopathic type of etiology. So this is a sarcoid uveitis patient who had poorly controlled uveitis, developed cystoid macular edema, and then developed a macular hole. And she was placed on topical therapy because in some cases that has been shown to close a macular hole, and she was also on oral prednisone. She was then given a dexamethasone implant, and her macular hole still failed to resolve. And so I did a vitrectomy, ERM peel, ILM peel, gas tamponade 5 days of face-down positioning, and she did quite well with 20/40 vision. The key here was the perioperative control of her inflammation, along with periocular steroids at the end of surgery. And so in the past, macular holes from uveitis were thought to have a worse prognosis than idiopathic macular holes. Well, it turns out with more recent techniques and surgical developments, as well as the tenet that we have to control perioperative inflammation, we actually can get pretty good outcomes with an improvement of visual acuity in this study, as well as good anatomical outcomes at around 80% in this study. Of course, it's a little bit lower than our rates of closure with idiopathic macular holes, but still quite good nevertheless. So now on to uveitic retinal detachments. So tractional retinal detachments don't all require surgery unless they involve the macula or they're threatening the macula. Of course, regmatogenous retinal detachments, which can be non-necrotic or necrotic, usually require surgery, and sometimes you don't have the benefit of being able to control their inflammation or infection ahead of time, and thus you have poor prognosis and high rates of PVR. Whereas exudative retinal detachment, we usually try to avoid surgery. We try to control it medically, either infection control or inflammation control. So this is a case of a 57-year-old gentleman who was immunosuppressed, had decreased vision in one eye, and had this chorioretinal lesion that was elevated and the serous retinal detachment. We did not operate on the serous retinal detachment. We controlled this medically. He ended up having a nocardia abscess. And after 4 weekly intravitreal amikacin injections along with systemic antibiotics with oral Bactrim, you can see that the lesion has regressed, but now this detachment with these membranes associated with the lesion seems to be progressing and is involving the macula. So this patient underwent a vitrectomy, and you can see me separating the anterior-posterior traction along this, and then also later looking for membranes along the surface of the lesion, which could be causing tangential traction. You can see that this patient developed an interval submacular hemorrhage due to a CNVM as well. And so this is me trying to get the membranes off the lesion itself and trying to relieve tangential as well as AP traction, and then giving anti-infectives with amikacin at the end of surgery, as well as anti-VEGF at the end of surgery, and then sending a specimen to make sure he wasn't still infected. And this is him after surgery, 1.5 years of follow-up. You can see all those membranes are gone. The retina is nice and attached. The patient did end up needing 10 injections of anti-VEGF, but had a good visual outcome with attention to those details. So uveitic PVR detachments are among the most challenging. So this is a 23-year-old IV drug user who had fungal endophthalmitis and then developed a giant retinal tear detachment. And then after a long period of time, oil was removed and then developed this really bad PVR detachment with hypotony and a hyperdeep chamber. And so this patient had vitrectomy. And what we did was we used OCT to guide peeling of those posterior membranes and then the anterior membranes. And then we decided to address the ciliary body membranes as well using an endoscopic approach, and so that we could treat the hypotony as well. And so this patient retained silicone oil, elevated intraocular pressure was hypotenuse and now is low normal, and then 2400 vision, but poor visual prognosis overall. So moving on to convalescent post-ARN rhegmatogenous retinal detachments, these occur quite often. In one study, up to 73% correlated with the extent of involvement, with lower risk in less than a quarter of the retina involved. There's several studies that have shown that prophylactic vitrectomy could possibly prevent retinal detachment in ARN, yet these studies are kind of fraught with selection bias and also low numbers. And in fact, this study showed that zone 3 had better outcomes without prophylactic vitrectomy. And this OTA that was put out by the Academy really showed with a Cochrane database review that there was no evidence to support prophylactic vitrectomy in ARN retinal detachments. Now, how do you fix retinal detachments when they happen post-ARN? The first tenet, of course, is to control the infection with systemic and intravitreal antivirals to try to decrease the number of clock hours that are involved in the ARN, the retinal necrosis. And then during surgery, the principles are really to remove traction, so elevating the hyaloid even if it's difficult to do, removing the scaffolds for PVR, such as shaving the vitreous base, as well as removing lens capsule if it's needed, and then improving long-term reattachment rates by making sure not to just laser the area of the necrotic breaks, but also past the areas of the visible retinitis to treat all the atrophic areas, and even if they look uninvolved or inactive, as well as considering long-term tamponade, and of course, using intravitreal antivirals at the end of surgery, potentially even sending a specimen. So retinoschisis is actually a relatively under-recognized complication of pars planitis and intermediate uveitis. Up to 50% of pars planitis have retinoschisis, and it's sometimes not recognized. This is a patient with pars planitis who had advancing retinoschisis despite good control of the inflammation. And you can see it on the B scan and the UBM. And it's thought to be a combination of etiologies, both tangential traction as well as an exudative component, which is why I treat these patients with cryopexy to treat the snowbanks, as well as a low scleral buckle to relieve the tangential traction. And I pair that with a periocular steroid. And in my series, they had either collapse of the retinoschisis or they had stabilization with otherwise progressive retinoschisis. So in summary, surgical complications of uveitis, they benefit from perioperative control of inflammation and infection. Preoperative planning is required for specimen handling and testing for the diagnostic portion. And then during surgery, really the principle is to relieve tractional components. So posterior membranes, anterior membranes, PVR, the exudative component with snowbank management, as well as intraoperative and postoperative treatment of underlying inflammation or infection. And the problem is that studies on surgical intervention in uveitis are often fraught with selection bias and low study numbers, and so really large, multi-center prospective controlled trials are imperative to guide surgical intervention for uveitic entities such as ARN. Now, if this is too brief and a little bit rushed, please consider attending the surgical management of uveitis patients instructions course on Sunday. That's going to be led by one of my colleagues, Danny Mamo. Thank you.
Thank you so much, Dr. Lin, for sharing those excellent results. And now we have an update on the management options for sickle cell retinopathy by Dr. Jennifer Lim.
Thank you so much, Don. It's my pleasure to give this update on the management options for sickle cell retinopathy, for which I have the following financial disclosures. Sickle cell retinopathy can be divided into non-proliferative, characterized by stage 1 arteriolar occlusion, stage 2 AV anastomosis, and proliferative stages, stage 3 neovascularization, 4 vitreous hemorrhage, and 5 retinal detachment. We learned from the Jamaican cohort study in a series of patients with SS and SC disease that only 10% will lose vision to 20/60 or worse. The vast majority, however, who do lose vision are due to proliferative stages compared to non-proliferative, with a relative risk ratio of 8.66. The most common causes for visual loss are vitreous hemorrhage, traction retinal detachment, and epiretinal membrane. When considering the surgical management for patients with sickle cell stages 4 and 5, we have unique considerations. Of course, there is the risk of sickle cell crisis, the risk of anterior segment ischemia, then the fact that the optic nerve is vulnerable even without glaucoma, and that the retina is very atrophic and thin. In order to mitigate the risks of systemic adverse events and decrease the risk of a sickle cell crisis, it's important to avoid hypotension, hypoxemia, and general anesthesia. You should keep the patient well hydrated and warm and avoid sympathomimetic agents. There is, however, no need for exchange transfusions. Let's turn now to the management of stage 5 sickle cell disease. The treatment options here include pneumatic retinopexy, which of course is uncommon and will not address the tractional components, and then scleral buckle and pars plana vitrectomy. We learned from Ryan and Goldberg in 1971 that scleral buckling essentially should be avoided because it contributes to anterior segment ischemia and elevated intraocular pressure, which will limit your visual acuity results. Jampol and coworkers at UIC in 1982 published one of the first series of vitrectomy for stages 4 and 5 sickle cell disease. And they showed that in 80% of patients with stage 4 vitreous hemorrhage, you could significantly improve the visual acuity. In patients with traction retinal detachment or combined traction rhegmatatus and vitreous hemorrhage in 10 patients, they showed that 60% could achieve attachment, but that anterior segment ischemia was still a problem, and that only 50% had improvements in visual acuity. Moreover, the rates of iatrogenic retinal detachments were high at 30%. Since then, multiple series have been done, which have shown improved visual acuity endpoints and decreased anterior segment ischemia. However, as shown by the series by Williamson, there remains a very high rate of iatrogenic breaks, 39% in this series, that required laser retinopexy or cryopexy with internal gas tamponade. And Williamson and coworkers recommended that segmentation instead of delamination should be used when treating these CFAN-related traction retinal detachments in order to avoid breaks and bleeding. I, too, recommend segmentation as opposed to delamination, and I prefer to use a 25-gauge shave mode. It's very important, as shown on the video here, to first release the AP traction and then to release the circumferential traction around the CFAN. I prefer to use a bimanual technique, frequently using a lighted pick and an ILM forceps in order to avoid damage and causing tears to the retina. It's also important to keep the intraocular pressure low so as not to damage the optic nerve. When done, it's important to laser around the CFANs and treat the areas of ischemia. Other series have also shown that smaller gauge vitrectomy, such as 23 gauge compared to 20 gauge, can result in slightly better functional outcomes and lower complication rates. Yet these series still show high rates of complications and retinal tears because of the anterior pathology and the very thin retinal tissues. However, both best-corrected visual acuity is essentially maintained or improved in 76% of eyes with rhegmatatus retinal detachments. However, when you do take care of these patients, realize that there's a high rate of recurrent retinal detachments, ranging from 29% in the series by Ho in 2018 to as high as 50% in Chen series in 2014. But this latter series included sickle cell eyes that had PVR. In our series at UIC, we have shown that vitrectomy for stage 4 sickle cell retinopathy can improve visual acuity from a mean pre-op vision of 2100 to a mean post-op of 2030. For eyes with retinal detachments, we could improve visual acuity from a mean of 2100 to 2040. We did have a rate of recurrent retinal detachment of 27%, but these were all successfully reattached. Let's turn now to stage 3 sickle cell retinopathy. We know that there are high rates of regression with proliferative sickle cell retinopathy CFANs. So the question is, do you treat or do you observe? Since regression can occur in approximately 30% of eyes. We learned from Farber and coworkers in the randomized clinical trial of scatter photocoagulation for PSR that laser is well tolerated and that the outcomes were better. In fact, there were lower rates of prolonged visual loss, 1% for treated versus 6.7% for control. There is also a lower incidence of vitreous hemorrhage, 11% for treated and 18.7% for control, and thus laser is generally recommended. It's recommended to perform laser 1 disc diameter anterior and posteriorly to the CFAN and 1 clock hour to each side. However, using that recommended treatment resulted in the similar rates of complete CFAN closure for both treated and control eyes, and also the same rates of new CFAN formation. So Rodriguez and coworkers studied post-mortem eyes to see why was this the case. And they found that in an area 2 millimeters surrounding the CFAN, there were increased areas of VEGF and HIF-1 alpha. And therefore, they suggest that perhaps treatment to these areas in a larger area of treatment perhaps could achieve better results in terms of recurrent CFAN formation and new CFAN formation. More recently, in 2023 and into 2024, we are now using anti-VEGF to treat proliferative sickle cell retinopathy. And you can see here an example of one of my patients with active CFAN formation treated with an anti-VEGF, and 6 weeks later, complete resolution of the CFAN itself. However, there's been no prospective study comparing anti-VEGF to laser, and so the ALP study is planned. In preparation for the ALP study, we performed a retrospective study looking at anti-VEGF for stages 3 and 4 sickle cell retinopathy. In our group of 37 eyes, we showed for stage 3 that visual acuity could be maintained at 2020 with good CFAN control. In stage 4, we showed improvements from 2100 to 2030 with good control of the vitreous hemorrhage. However, in this series, obviously, there was a retrospective series, and the anti-VEGFs were combined, some with laser, some with later vitrectomy, and some were anti-VEGF alone. Yet for 95% of all of these patients that had stage 3 or stage 4, visual acuity was stable or improved. So in summary, the management options for sickle cell retinopathy in 2024 include for stage 3, anti-VEGF versus laser, for stage 4, vitrectomy versus anti-VEGF, and for stage 5, recommend vitrectomy. Thanks for your attention.
Well, thank you, Dr. Lim, for a talk so filled with practical tips. Our next presentation is by Dr. María Berrocal, who will speak to us on new buckling techniques. Let there be light.
Well, I want to thank the organizing committee for inviting me to speak to you. These are my financial disclosures. Well, we know that for phakic eyes, we get best visual acuity outcomes and single surgery success rates when we perform a scleral buckle versus a vitrectomy, 91 versus 83% in most published series. There's no need to position. There's faster visual acuity recovery. Convalescence time is reduced. There's no cataract progression, no flight restrictions. Despite this, over 80% of all retinal detachments are treated with vitrectomy worldwide, and in the US, it's over 90%. And we know from recent data that vitrectomy, when you have a MAC-off detachment, causes retinal displacement, with 42 to 58% of patients describing anisoconia and 50 to 90% of patients describing vertical metamorphopsia afterwards. And young surgeons prefer vitrectomy, partly because they have limited exposure to scleral buckling techniques during training. And this is because it is very difficult to learn something that you cannot really see, and poor visibility during surgery is a real issue with traditional scleral buckle. So traditional versus chandelier scleral buckle surgery. The problem is that in the past 75 years almost, traditional scleral buckling hasn't changed. We use loops for visualization instead of a microscope. In direct scope viewing, which gives us a very limited view, particularly in pseudophakic eyes. We have to do it standing, it's inconvenient. And the assistant has no view of what's going on, so it's hard to teach, how to cryo or where the breaks are, etc. But when we use a chandelier while we're performing a buckle, we take the advantages of the microscope visualization and magnification. In what I'm going to describe, I also use the 3D visualization, and we use wide-angle viewing like a biome, etc. So when we look at the complications of scleral buckles, most of them are due to poor visibility. Missed breaks, improper buckle placement, fish-mouthing phenomenon, subretinal bleeding, like that case on the right, during drainage or suturing of the buckle, retinal incarceration, damage to the muscles, vortex veins. And when we think about encircling buckle, which is what is mostly done in the US, we cause refractive change, which is a problem for patients with premium IOLs, mostly a myopic shift. We can get anterior segment ischemia if it is very tight, and we're really suturing attached retina in many cases with the possibility of perforation. So what I'm going to describe is using a chandelier scleral buckle with wide-angle viewing, 3D digital visualization using radial or segmental sponge exoplants. In the technique, I'm using a microscope, a biome, and the Ingenuity system. And there you can see in the top picture how well you can see these areas of thin sclera when you do all the suturing under the microscope. So we open the conjunctiva and tenons. You don't need to open 360, you just have to open the quadrants where the pathology is. You place a chandelier 90 to 180 degrees away from the breaks. Use the biome to examine the retina and mark the breaks. Cryotherapy to breaks, and laser indirect afterwards if you want. And you suture radial or segmental sponges. You can drain or not drain. And if the eye is hypotonic at the end, intravitreal air, you suture the chandelier sclerotomy site and close tenons over the conjunctiva. And this case really exemplifies it nicely. You know, we are opening here. This was a 60-year-old woman who presented with this Mac-off detachment actually 2 days before Christmas, and she was traveling to see her children in a week. And here you see how well the assistant can see this, and you can actually teach what's going on. And in this case in particular, we saw when we were doing cryo small breaks around the main break, which may have been missed during the exam, and you trim. You cut the piece of sponge, and the distance between the sutures is really what determines how much indentation you're getting from this. And you check the positioning with the biome, and then you do these slits on the sponge so that the sutures bury in and it won't move from where it is. And then, in this case, I'm draining, but you don't need to drain in many cases. And you do the suture, you know, you're doing this under the microscope, so you see really, really well, and then you check that everything is in place. And I, in particularly, in this case, it was hypotonic, as you can see, so I inject air into it. You can inject fluid also. And then, you know, I always suture the site of the chandelier, and then you trim the edges of the sponge. And the most important part of this is really suturing tenons over the sponge. And for the sponges, we really have to give credit to Dr. Linkov, who described the sponges in 1965, and he also described the cryotherapy for us. So once you close that, then you close the conjunctiva, and this is immediately the next day, and this is 1 month afterwards. So advantages, microscope view instead of loop magnification. You get the same fundus view as doing a vitrectomy. It's ergonomic. For teaching, it's great. No refractive change. And a meta-analysis of 30 publications of over 1,000 eyes showed primary reattachment rates of 91.7, surgical time reduced 19 minutes versus conventional sclerobuccal, and no difference in attachment between phakic and pseudophakic eyes, and no cases of endophthalmitis. So in conclusion, this reduces complications due to poor visibility, optimizes teaching capabilities. It's ergonomic. It may reduce retinal displacement in cases that are MAC off. And as we can see, it may improve outcomes in pseudophakic eyes treated with scleral buckles, since we can really see really well the periphery. So thank you for your attention.
Thank you so much, Dr. Berrocal. It's always a pleasure to see your masterful surgical videos. Our final speaker in the talk section will be Dr. Aleksandra Rachitskaya, who will speak to us on imaging biomarkers for post-retinal detachment surgery. When is imaging necessary?
Good afternoon, and thank you, Don, and thank you to the organizing committee. It's a pleasure to be here. These are my financial disclosures that are not relevant to this talk. So why are we talking about imaging biomarkers in rhegmatogenous retinal detachment? Well, maybe it's time for us to move on from thinking about a success in retinal detachment as single surgery success rate or anatomic success. In fact, we've seen that imaging biomarkers have been proposed to predict anatomic and functional outcomes in patients with rhegmatogenous retinal detachment, and also aid us in decision on surgical approach and maneuvers. So let's start preoperatively. It used to be that you would see a patient with a bullous rhegmatogenous detachment, and the OCT would be such poor quality that you wouldn't be able to see anything. But now, in a case like this, you can image and you can identify a macular hole that potentially could change your surgical management. But as we look further, we can see that the extent of macular detachment and the presence of macular edema has been reported to be associated with worse prognosis. And there's other biomarkers, such as height of the detachment, the presence of outer retinal corrugation and their size and shape, as well as bacillary layer detachment, as is shown in with this orange triangles, where you have the split that is bound by ELM and the photoreceptor inner segment myoid. We also learned that continuity of external limiting membrane and ellipsoid zone preoperatively is a predictor of postoperative BCVA. In the first image, you see that both ELM and EZ are present. In the second one is just ELM. And in the third image, both ELM and EZ are absent. We see other biomarkers, such as hard exudates, that are found in outer retina and subretinal space. Those are postulated to be photoreceptor debris or potentially inflammatory cells. And these baseline hard exudates have been shown to be associated with reduced postoperative vision, as well as occurrence of CME, but not association with ERM. Of course, when we see these patients, we also want to see what the status of the PVD is. And this is an example of my patient who came in, and you can clearly see that the hyaloid is down. And even in the presence of subretinal PVR, we did a primary buccal, and this patient did extremely well. But sometimes it's hard to see if there's vitreous schisis, and presence of vitreous schisis could potentially change the way you would manage a patient. It's sometimes tricky to identify this vitreous cortex remnants that are present on the ILM. So looking at such biomarkers as preretinal hyperreflective layer, as shown here with the arrows, or sawtooth aspect to the retinal surface, when compared to intraoperative evidence of the presence of vitreous cortex remnants, both of these OCT findings were significantly associated with presence of vitreous schisis. But as we think about this preoperative imaging, what's lacking and what's been proposed by some of the leaders in this field is that we need to think of staging of rhegmatogenous retinal detachment and looking at the extent of RD, the height of it, the presence of such biomarkers is outer retinal corrugations, intraretinal fluid, presence of discontinuity of ELM and AZ, and hyperreflective foci. So what about intraoperative imaging? There's been a lot of work that's been done at Kola Institute looking at intraoperative imaging, and it's helpful for identification of such things as full-thickness macular holes. But more interestingly, it was also found that if you look under PFO, you might see presence of intraoperative subretinal fluid. An increased volume of this subretinal fluid tended towards significantly worse visual outcome for these patients. What about postoperative? So we, of course, want to avoid these kind of findings of cystoid macular edema, epiretinal membrane, residual subretinal fluid, and retinal folds. And there's ongoing discussions among all of us looking at the best ways to approach patients with different types of rhegmatogenous retinal detachment, both in approach, be it pneumatic retinopexy, segmental or circumferential primary buccal, primary vitrectomy, or buccal vitrectomy, but also going beyond that, discussions of how should we remove the ILM or how we should position our patients postoperatively. And then looking at the microstructural integrity is becoming more and more important as we try to figure out, once again, what is potentially the best approach for different patients. And here we can see in panel A, normal OCT. In panel B, we see the discontinuity of ellipsoid zone. And then panel C, both external limiting membrane and ellipsoid zone. Retinal displacement, something that Maria just alluded to, can be detected by fundus autofluorescence as we look for this hyper autofluorescent lines that correspond potentially to the prior locations of the retinal blood vessels. And what I think is interesting is that we want to image those patients long term. This is a very nice example looking on unfast OCT of the EZ slab. In panel L is contralateral normal eye, but panel A through K shows the improvement in EZ slab over 6 years. So historically, we would tell our patients that they probably stabilize after 1 or 2 years, but it probably takes longer than that. So as we take all of this together, we continue to learn about the role of preoperative, intraoperative, and postoperative imaging biomarkers when it comes to the choice of surgical technique and maneuvers, and also as it applies to anatomic and functional outcomes in rhegmatogenous retinal detachment. But to do it better, we really need to have a much clearer classification of retinal detachments, and also the way we assess outcomes. When it comes to functional outcomes, we need to look beyond just standard BCVA and look at measures of metamorphopsia and anisoconia and potentially effect on activities of daily living for those patients, and anatomic outcomes looking more at the microstructures. And I thank you for your attention.
Well, thank you so much, Dr. Rachitskaya, for encouraging us to look ever more carefully at our retinal detachment patients. We will now invite Dr. Gaurav Shah and his panel up to take us into the next part of the session.
So thank you. As the panelists come up here, for the timer, people, let's start the timer when they're seated. So we don't want to lose any minutes for our panel. So as they're getting seated, we have a lot to get through. As soon as everybody gets seated, we will start. Stana. So all these people, they don't need any introduction, but I will. We have Dr. Eliott, Dr. McCannel, Dr. Oshima, Dr. Rizzo, Dr. Pertile, Dr. Vajzovic. We have kind of a national and international panel of superstar surgeons. So I get a chance to talk to them, and you get a chance to listen to them. Dr. McCannel, dilemma in 2024, we know that macular hole surgery is very successful. We hear a lot of talk about ILM gymnastics, all these flaps, done many different ways. What do you sort of base this on if you do these? Is it on the duration? Is it myopia? What do you base ILM gymnastics on if you do this?
Well, for standard holes, simply complete vitrectomy and ILM peel limited to include the fovea. But for chronic holes, reops, I usually take the ILM and place it over the hole. And in really chronic cases, I'll detach the macula with a subretinal injector as well.
Okay, so you really base it on chronicity and maybe refraction. So because we know macular hole surgery is quite successful, but there are patients who have this, where they have failed or atypical holes, and we kind of have these different techniques. We're going to talk about the hydrodissection, autologous retinal transplant, or an amniotic membrane transplant. So for Dean and Yusuke, Yusuke's video is on the left, Dean's is on the right. Can we go back here? The video the video's not playing. So can you describe the technique for Yusuke on the left? Those videos are not playing.
It's around Dean's surgery.
Yeah, so Dean's video. So Dean, tell us what you're doing here.
So this patient has macular telangiectasia and a macular hole. The patient had surgery elsewhere. The hole didn't close. You can see the OCT on the bottom on the left. The edges are relatively flat. So we put in blue dye to see how much ILM was peeled on the prior surgery. It was a small area, so we enlarged it. That's why you can see the little petechial hemorrhages. And then we decided to do hydrodissection, so we did 4 little blebs on the temporal side and made sure that the fluids surround the hole completely, and then you could see the healing on the other 2 OCTs on the bottom, and the patient went from 2100 to 2050. This is another patient that had failed macular hole surgery, and the edges were flat. And this was similarly done with the hydrodissection blebs. You can see the 4 dots on autofluorescence, and this patient had closure and improvement.
So Oshima, how many blebs do you create? Do they all connect? Do you have to use PFO? Because that's kind of what your video showed.
Show my video.
It's not playing for some reason. So.
No, sir. So my case, I had to show that case. My case is not only the macular complicated with rich detachment, it's not related to the high myopia. It's a vitreal macular traction, long-standing macular traction. So the case is not easy. You simply use the island to cover something. So that I like similar to the technique, use the bubble. But after remove the island, I just use the needle touching to the surface of the retina with a small injection current to make the small bubbles just around the macular hole to make the facilitate relaxing the edge of the macular hole and dilute the high viscous subretinal fluid.
Okay, can I ask a really simple question? Dean and Oshima, do you like to have fluid come through the hole or not? Yes or no?
Yes, I do. That indicates my bleb is contiguous with the hole.
Okay, because some people, put PFO and all that, so you like to have the volcano effect. Okay, so we have this patient who has a macular hole that I saw, who had previous surgery and had an amniotic membrane. And Lejla, so we're going to go to my video on the left, Lejla's is on the right. Lejla gets done much quicker. So the issue, Lejla, I had on the left is that I had the amniotic membrane was kind of moving around. And I don't know if you have any hints, but I ended up just going to an air fluid exchange and doing it that way. I don't know if you have any hints to prevent this. Also, as we'll get into, does it really matter what side is up or down? Because I can't really tell what side is up there. Lejla?
Yeah, thank you. No, I think it's a challenge to keep it there, but I think steady, slow aspiration can help. At times I will use glue type agents to keep it in place. I know Stano has introduced this technique, so I'm sure he has many more tips, but I have used platelet-rich plasma in the past, and you see me kind of adopting that technique to keep the transplant there.
Yeah, and I just use viscoelastic. So speaking of Stano, so Stano really kind of, we learned this technique from him 5-6 years ago. So Stano, when people are first doing this, these are the questions. Does it matter what type of amniotic membrane? Is it cryopreserved or dehydrated? Does it matter, Stano?
There is some difference. The cryopreserved, of course, is richer than of growth factor or proteins. Also, but basal membrane is different. But of course, the advantage to have the dehydrated is always very easy available. You can use as all the tools in your closet. Okay,
and do you typically, does the orientation matter to you?
I think so, because of course the epithelium layer can allow the photoreceptors to slide over the membrane.
Okay, and do you ever put this either under the retina?
Yes, I prefer under the retina, but of course the maneuver is more delicate. You can touch the retinal epithelium, you have to elevate edges, but of course I think you don't need the endotamponades if you put under the retina.
Okay. So this is another San Francisco special patient with previous surgery, now with a retinal detachment and a macular hole, high myope. And on this patient, Lejla, this is somebody who had a retinal allograft. Let me kind of show your technique, and maybe you can comment, where do you take your graft from, and how do you prevent slippage? And again, same thing here, does orientation matter?
Orientation does matter. Supranasal location. This is the technique that Tamer, Mahmood, and Dilraj Grewal have nicely introduced for us. I think your earlier question for me was how do you maintain that flap, amniotic flap in place? And you'll see me nicely playing with this flap, this transplant as it's moving around. I like using PFC to help me keep the transplant in place, but at times I'm still using something on surface like a glue type substance, and this was a platelet-rich plasma that was injected over the transplant to help stay in place. This is a high myope patient, so really being very slow in aspirating fluid and being very thorough there is key to ensure a location stays in place in terms of transplant.
So for the audience, for this, use PFO for typically amniotic membrane. You don't do it under PFO.
I do not.
As a general point.
You saw me separating the transplant, and as I was getting kind of a little tiny flap left, I introduced the PFO to help me keep that in place as I transfer it towards the center macula.
So here's another patient, Stano. This is somebody who has a recurrent detachment after oil. And maybe describe that.
Something new. This, of course, it was a recurrence after silicone oil. He has this break on the metrophic area on the inferior temporal quadrant. First, of course, I prepare some cyanoacrylate glue, the same glue we use for cornea. I use this kind of in this surgery, the silicone oil injector with 41 needle, you see, and under air, of course, I exchange the perfluorocarbon. I put some small drops. It's enough 1-2 drops on the area of the break. you see, in order to fix. And then I introduce another time BSS, and now we have no tamponade in the retina, the retina remains attached, and they put some laser on the edge on the retina, so also to test if the retina is completely attached. But retina is attached completely without any tamponade at the end of the surgery, so this is a great advantage to have no hair, no cell. It is after 1 month. Now, of course, I follow up this patient at 6 months. You see no tamponade, the retina completely attached. You see, of course, the image is inverted. You see the area of the glue completely restored.
Stana, you're always seeking something new. This has been reported in eyes with fever, but this is a commercially available product. So this is another thing that we see, Grazia, myopic traction maculopathy. It seems like we see more and more of this. In this case, we're talking typically about myopic foveoschisis and foveal retinal detachment. Where do you intervene, the one on the left or the one on the right?
No,
that's the hardest question here.
No, it is not so hard as question because I intervene in the one at the right. When there is a foveal detachment, I think it is really risky. It is reported that there is a lot of literature about, and I think it is worthwhile to intervene, even though it is not easy to intervene in high myopic eyes. And I do an ILM flap technique to protect the foveal area in all the myopic eyes.
Okay, a question for Oshima. This is your technique for the traction maculopathy.
Yeah, basically in that case.
Can we play his video?
Because this case without any subfoveal fluid, so basically the case very simple. We only perform the foveal sparing ILM peeling, and could you run the video?
Yeah.
And finally, after we're lifting out the ILM at the edge of the fovea, and we use the cutter to trimming the edge and left the ILM very small area there.
So unfortunately, these were all playing about an hour ago. Let me just give an example. So you had ILM sparing peeling, but let's say if somebody's peeling and the ILM comes off, how does that change your management for this patient?
Basically, if the case without macular hole or something, we never put any gas or something because we published a recent paper, the multi-center study, we found that the patient, if with the air compression, maybe found much lower visually coverage than without the gas or air. So that means the reason why our injury surgery only do the ILM peeling with for the sparing peeling without any air or gas.
So typically no tamponade.
Yeah,
okay.
sure.
So we talked about this. So this is becoming an issue that somebody I know is going to be facing right now as they're coming to Chicago today. So they're seeing on a Friday a macula-threatening detachment. So we'll go around the room. For in Japan, when would you do this, Oshima?
Basically, my practice is office-based surgery. So basically,
you have options, Friday or Saturday?
Yes, Friday night or Saturday morning.
Okay, Dean?
Friday night.
Friday night. Tara?
Saturday morning.
Okay, Lejla?
Saturday morning.
Stano?
Monday.
Grazia.
The one at the bottom is a chronic detachment, so on Monday.
Monday,
and the one
okay.
on below.
Well, the Italians are smart. Patch and Monday. I like that approach.
Weekend is holy.
So one of the things we've gotten into is we were classically taught that pneumatic. These were the classic patients: phakic, single break, no lattice, the upper 8 hours. Now we've gone into pneumatic, kind of these extreme candidates: bridging vessel, multiple breaks. Break in inferior, superior break, but you have a break in attached retina inferiorly. So Dean, these are the expanding indications. Out of the ones I've listed here, do you still follow the typical things that I guess all of us did, but now for good reasons, there's maybe some changes because of OR time and so on and so forth. So which one of these things here that are listed that you would say, okay, no matter what, I'm going to still do a regular, vitrectomy surgery or buckle?
I tend to do pneumatics only when I think it's going to be a slam dunk. So I'm pretty conservative. I'll do it if there's 1 or 2 breaks that are close together. All this other stuff I won't do. Maybe the mild vitreous hemorrhage if I can see well. But all these other things, we have vitrectomy and it works great. So I want my pneumatics to work. I want my vitrectomies to work. I don't want failed pneumatics.
Okay, I know Europe, obviously in Asia, pneumatics are really not that common. But Lejla and Tara, any questions? Similar?
I'm there with Dean.
Yeah,
Okay.
similar.
All right. So
similar.
that should make it easy. Okay, so failed pneumatics. Now, if a pneumatic fails, Tara, do you do kind of repeat pneumatics? Do you do primary vitrectomy, or say, you're going to need the definitive procedure, vitrectomy buckle? Because I see this question come up.
Well, it depends how bad things look. I mean, oftentimes, you can just do a buckle
Okay.
if it was a pneumatic patient anyway. And then if there's more PVR, you can do buccal vitrectomy.
Lejla?
Yeah, it's exactly the same
And
combination.
Stano and Grazia, you don't have any failures of pneumatics because you don't know them, so I'm not going to ask you the questions. Grazia, this is a stickler's patient's right eye who had surgery, has done well by Rich McDonald in our practice, 2020. The question is, here's the left eye. How do we prophylax this patient? Do we do laser anterior, posterior to the lattice? Do we treat radial lattice? Or do you even think about doing a prophylactic sclerobuckle? Grazia.
No, I do laser anterior and posterior Uveitis area. I don't do prophylactic sclerobuckle because the adhesion and the traction are at different levels, so I don't think it's going to help.
Okay, Stano?
Laser everywhere.
Laser everywhere. Monday, though. Not Saturday, but Monday. Okay. Yusuke, what would you do in Japan for this patient?
We did the proximal laser.
Prophylactic, okay. But nobody would do a buckle?
No.
Okay. All right. So again, these are tough patients because they've had a problem, obviously, in the other eye. So, methotrexate has now become more and more common, obviously, for primary retinal detachments that have PVR. But the question comes into is there use? There's now, we've been doing this. There are other groups that are doing this. And thanks to Dean Eliott and his sort of thought into all of this, Lejla, do you think about maybe giving methotrexate for prevention of PVR in these high-risk eyes, multiple breaks, vitreous hemorrhages? It's not that expensive, but I'd like to get your thoughts first.
I've had great luck with methotrexate post. I have not used it in prevention, but I think it's a great idea.
Okay, Stano, Grazia?
Waiting for some results.
Waiting for the results. Yep. Tara?
Just as the studies show, we do it after.
Afterwards, yeah. And again, I think there's sometimes more and more thought to, because once we know PVR starts, it's a process that despite all our beautiful videos, it becomes a hard process to control. So this is, we see more and more patients that despite anti-VEGF therapy, that they're on Plavix or these medicines that actually you will get a hemorrhage despite being on anti-VEGF therapy. So Tara, when you see a patient like this, we have kind of three options, right? You can just continue with anti-VEGF, you do office pneumatic displacement, or you do something in the operating room. Well, what is sort of your approach in these patients?
I mean, if it's fresh and the blood in the history is recent, I think taking them to the operating room and doing subretinal TPA is what I like to do. Okay, and this is your video, so kind of just walk us through the technique. Anything that you like to do, any instruments? So I like to use a 38 gauge subretinal injector and I use 12.5 micrograms of TPA per 0.1 cc, and I just create enough bleb to create a detachment that you can imagine the blood could go into. In this video, it shows it inferiorly, and I do a 50% air exchange, because if it's too filled with air, the blood might not move. Then I have the patient position for an hour post-operatively in the recovery room on their back, and then I alternate vertical and face down after that time. Okay, so you go back, face down, and kind of like a rotisserie type stuff. Yeah. Okay, Stano, what do you do?
I try first to do pneumatic and TPA, no vitrectomy.
So in the office?
Yes.
No,
unfortunately, we don't have office in Italy.
Yeah.
Just
okay.
OR.
Oshima, what would you do?
We do the same, the TPA injection with the pneumatic displacement.
Pneumatic, okay.
Yeah, fresh case.
So Grazia, you have an interesting technique that we'd like to, can you kind of walk us through what you're doing here?
Yeah, in case you do not have enough displacement and the only eye is involved, you can consider a macular translocation. So you need to detach the retina, do a retinotomy, and then you are able to approach the clot and the scar tissue. And you see, you can remove all this hard clot. Of course, you cannot do anything with pneumatic in this case. Coagulate the feeder vessel, and then you can gently rotate the retina on a healthy area of RPE and put silicone oil in. It is really for selected cases, but
and this was a monocular patient, so did you rotate that down, or how did you rotate this?
Upward, depending on how you rotate the muscles, but you rotate upward where you have a healthy area of RPE. And this is why it is useful to displace the blood, so you can check that the RPE in the right position is still healthy and it is worthwhile to do the procedure.
So we had three really different procedures. One was pneumatic, the other one was intraoperative of subretinal TPA, and the other was rotating the entire retina. So when a disease doesn't have great outcomes, you get multiple procedures. So Tara, walk us through this case. This is somebody who had a melanoma and had a retinal break, so that a rhegmatogenous detachment with a melanoma. And here's the ultrasound. And tell us what you did here.
So the most important thing is, obviously, when you have a retinal detachment, you want to look for melanoma because it could be a serous situation, but clearly here there's corrugations to indicate a break. And you don't want to delay fixing the retina. It takes time to prepare radiation treatment and brachytherapy, and in the meantime, PVR is progressing. So treat the break. We did a pneumatic retinopexy first, and then the patient underwent plaque vitrectomy and silicone oil, and has done well. The retina stayed attached, and oil came out doing great with 20/40 vision. So treat the retinal detachment. Don't just leave it and worry about the cancer. Just fix the detachment.
And do you do anything special at the time of vitrectomy in terms of your wounds or whatever? You're worried about cells coming out. Do you ever worry about that?
Just do what you normally do.
Okay, from an oncologist. Okay. The last 1 minute, Dean, we always get these text messages from the referring doctor. It says, hope you're well. Can you please remove and suture an IOL in? If you can do it this week, would be great. Have a great day. So this is kind of the text message we get. And I firmly believe that we have all this IOL gymnastics because there's a lot of pressure from referring docs to put something behind the iris, even though what is in front of the iris may just work as well. So Dean, this is a 66-year-old healthy retired retina physician who has a dislocated lens, and he didn't want to go to Italy and see our colleagues in Europe. But what is kind of your lens of choice in this in the last 30 seconds, Dean?
I like ACIOLs, low complication rate, intra-op and post-op.
Okay, Lejla?
Scleral fixation.
Scleral fixation. Okay, Yusuke? You do Carvalho?
Now we don't have it, so it's a scleral fixation.
Okay, Stano?
It's trapezius lens, sclerification, otherwise Carnevale.
Okay.
That's either option, artisan lens or Carnevale lens.
Dr. McCannel,
Scleral
last shot.
fixation.
My preference is anterior chamber intraocular lens like Dean. I think they're the best.
Okay, that is my as well, so we're going to end with that. Okay, thank you so much.
Bravo, bravissimo.